Full screen, we can hear you, everything fine. Please go ahead. Thank you.
I will switch off the camera for now.
Yes, please. Yeah.
Okay. Good morning. I will be talking about imaging and radiotherapy and in-particle therapy. In fact, most of the talk will focus on particle therapy, but in the beginning, I'll talk primarily about imaging and all of radiotherapy. So a lot of the talk is centered around this review paper I wrote 5 years ago, which is the imaging state of the art and future perspectives. And I usually like to break up the imaging into 3 stages, which is the pre-treatment, the stage 1, during treatment, which is stage 2, and post-treatment, stage 3. So there are 3 phases effectively where imaging is relevant, and we always should consider them separately because they have different implications. The pre-treatment imaging is really the most important, and it's what sets the stage for all the type of therapy that we're going to give. And one of the imaging parts is to do tumor staging. So the doctor has to know how to treat the cancer and how to deal with it. And so usually this staging is usually done with a PET-CT or PET-MRI or even just a CT. This is critically important for the clinician, so the staging is the first step. Then in the case of radiotherapy for particles, we also have to do something that is coming up now, which is the dual energy CT. So dual energy CT is something that is becoming standard in proton therapy and carbon ions. In most photon therapy centers, you just need a single energy, but I've put here the dual energy to mention specifically the stopping power. And then something that is really important before treatment is to understand if the tumor is moving, okay? And so this is usually related to respiratory and breathing monitoring systems, which can be done through X-rays or MRI or stuff like that. And I will mention this in more detail. Okay, so that's the first stage. The second stage is the during treatment, and this is of course the second most important. And this allows you to monitor what's going on every day. And so this is usually done in room, or preferentially should be done in room. So tumor motion monitoring and adaptation should have an in-room system, either X-ray based or potentially in the future for protons, MRI based, or even for the MR-Linac, which is the case for the photon beams. And also you want to do positioning of the patient using either CT or cone beam or even potentially MR. This is extremely important because it allows you to treat the patient every day in the same position. And this is usually the setup and alignment that is needed daily for treatment. And then of course, you also want to try to do beam range, beam monitoring, and this can be done with things like prompt gamma, which I will also mention. Okay, and then the final part of the imaging is always the post-treatment. And this is the part that is usually forgotten. Most patients, once they go out of the clinic, they have only 1 or 2 additional images over a period of 2 years, and they tend to kind of disappear. So it's really important to do treatment response follow-up as many times as possible to get an idea of what's happening to the patient, what's happened to the cancer. And this can be done with a variety of imaging systems like PET-CTs, PET-MRI, or even just a CT. Okay, so let's start with the pre-treatment. So the pre-treatment, one part that is really critical, and it's the clinician's responsibility, is the so-called tumor staging. And that is really important that you often understand what it is. So there are 2 steps to this tumor staging. The first one is the rating that is done at the clinical stage, and that is usually done either with a PET, an MRI, or CT, or even a biopsy, or even a mix of these 2 things. So that's the first rating of your cancer. A second rating can be done after treatment, such as a surgery or something like that. And that is usually called the pathological stage, where you analyze the cancer post-treatment. The tumor staging follows a standard procedure, which is called the TNM staging system, which represents tumor, node, and metastasis, TNM. And this is the most often used for doctors to understand what grade of cancer they are treating, if it's grade 1 or grade 2 or grade 3 or grade 4. If you recall the lesson I gave on Monday, there were 4 grades to the cancer. The grade 1 and 2, the tumor has not metastasizes, so there is no metastasis, or nodal, usually no nodal involvement also, while grade 3 and grade 4, you do have a metastasis. And then this is the key is this is the responsibility of the clinicians, but the medical physicists have to do this. They have to also be responsible for setting up all these imaging devices that are needed. Okay, so what are the imaging devices? There are a huge variety of them at the moment. I will start with the X-rays, which is the simple X-ray image. Then there's the computed tomography or the CT. Then there's the MRI, the PET and the SPECT, where PET stands for positron emission tomography, and the SPECT stands for single photon emission computed tomography, computerized tomography. And there's also the ultrasound. Okay, so in the case of the X-rays, the big advantage is that bones have calcium and phosphor. And this makes it a very high absorption of X-rays. The low energy X-rays have a photoelectric absorption, which is extremely high, and that allows us to see bones very clearly when we do X-rays. So another way of calling X-ray imaging is called bone imaging. And so it offers us extremely good structure of bones. It's good for detecting also metal objects, which are also high Z. So calcium is a medium Z, and metals are usually high Z. And so any X-ray system will be able to see them really, really well. The problem of X-ray imaging is the soft tissue. Since the soft tissue all has approximately the same attenuation coefficient, it's really hard to distinguish soft tissue in X-rays. So one big evolution of X-rays is the computed tomography, and that was developed in the early 70s, 69 to 71, by Gottfried Hansel. And effectively what you're doing is you're taking a projection of the patient in all directions. So you can see here on the left, you have two types of rotating X-ray tubes. One that is taking a fan beam, so it's a very narrow, thin beam of the patient, and one that is taking a cone beam, which is the one on the right. And what you do is the X-ray machine rotates all the way around the patient and takes a full 360-degree image of the patient. Then you basically do the reconstruction using radon transform. So you need to know how that works. And then you need to do a filtered back projection or iterative reconstruction to build the images. And eventually you build an image that looks something like this. This is, for example, a lung image when you can see a lot of structure and you can clearly see the bone. So one thing that is usually important to understand in an imaging is that everything that is background is black, or low density is usually black. So you see on this image on the right, you see that the background is all black, or the low density part of the lung, which is also black. While the bone is usually high intensity, so white. And so everything goes from black to white, from low intensity, low density, to high intensity, high density. So one of the hardest bones are these cortical bones that form the spine, and you clearly see the spinal structure with the spinal cord.
Ok, mi sa che l'ho mutato, credo. Mi senti? Ok. Ascolta, no, stavo pensando una cosa. Allora, effettivamente, vabbè, ho verificato perché io i risultati non li ho visti, come bene hai potuto capire. E stavo verificando appunto se effettivamente per la riproducibilità.
Okay, so maybe I continue after this small interruption.
E no, in realtà è tutto corretto. Quindi...
Okay, maybe I wait
participants, please switch.
Okay, so shall I continue from this interruption then? Hopefully it's over.
Okay.
Eliana, please switch off your microphone.
Okay. Fantastic. Okay, anyway, so coming back to the CT on the right, just a quick reminder. The black represents low intensity, and that corresponds to low density or air, or as low as possible. The white represents high intensity or high density, and you clearly see the bone structures, okay? And you even see a small white calcification here in the middle. Okay. Ooh. Okay, here is the evolution of CT imaging in the last, say, 50 or 30 years. The first CT device was extremely slow and would acquire basically a rotating detector with a rotating source. Now what we do is we either do multi-fan beam development, which is this one here, where you have multiple fan beams. So you have a variety of detectors on the bottom, or you can even do the very fast CT scanners, which use cone beam. And so in one rotation, the Toshiba CT scanner can do the whole image of the patient. So these are more or less what you do. You rotate everything around. Okay, Now we're going to move into magnetic resonance imaging, and this is based on nuclear magnetic resonance. Although the name changed because of the fear of the word nuclear, so our field MRI has become called MRI because of that. The word nuclear was dropped. Okay, in the case of MRI, the big advantage is we get a lot of really good soft tissue information. We have extremely good contrast of soft tissue. And what we do is we build an MR image without the need of any type of radiation. So there is no radiation to the patient. And this provides us an excellent way of imaging without side effects. And it's based on the principle of nuclear resonance imaging. So I will move on to that. So what we image, we primarily image protons. And we need to have the proton to have an odd spin. So the nucleus of the proton has to have an odd spin for it to appear in the MR. And what we measure is the protons. In fact, we measure specifically the protons in water. So that's what we tend to see. Other protons in other materials are usually harder to see. So we tend to primarily focus on MR in protons in water. And they are very good for measuring soft tissue contrast. And so we can see really tiny details of the cancer in the MR, in the soft tissue, which is practically impossible to see in a CT. So MR is primarily used for contouring. And it has a region where you cannot really identify the boundary of the tumor. You would preferably use an MR for that, not a CT. The CT is usually more for a bulky design of what's going on. So what we see is not only proton density images, we see proton density images, and we see time curves, right? The T1 and the T2 are decay times of the tissue, and that offer this ability to see the soft tissue. And when we do the recording of the images, we usually do that in frequency space, where we then build the images from there. Now, you might ask yourself, why are the MR magnets getting stronger and stronger? Why do companies sell us every year a magnet that's even stronger? So why has it gone from 1 Tesla, 1.5 Tesla to 3 Tesla? Now the clinical standard is becoming 7 Tesla. The reason is noise. The big reason is that as we increase the magnetic strength, we improve the signal to noise ratio of our image. And in short, that means I can see small details well. I can basically see the edges of my tumor much better. The big advantage of increased magnetic strength is the increase in signal to noise ratio, which means I can see the tiny edges really, really well. Okay, another imaging modality is the PET SPECT, and both of them involve the emission of particles. In the case of the positron emission tomography, you have a radioactive element that is emitting positrons. In the case of SPECT, you have a radioactive element that's emitting gammas. And in both cases, you then reconstruct the intensity from where that it's emitting. So you have a source inside the patient somewhere that is emitting either positrons or gammas. So positrons are beta plus or gammas, and you are going to accumulate that information. So here, for example, you see, for example, these white dots here on the right represent your possibility of high accumulation of these positrons. The most common tracer for PET is FDG, while the most common tracer for SPECT is technetium. So FDG, for example, is a sugar. And the big advantage of using a sugar is that cancer usually has an extremely high uptake of the sugar through the process of glycolysis. I don't know if you recall the lesson I gave on Monday. I discussed the Warburg effect and how the cancers prefer to have a so-called glycolysis mechanism to produce energy. Well, this gives us an advantage to see them, because if we inject cancers with sugar, they appear as a bright dot of where all this consumption is occurring. So it gives us an immediate location of where all the glycolysis reactions are happening, and we can really characterize that region as the most resistant part of the cancer. So PET is really perfect to understanding where the cancer is most resistant, and where we really have to use like carbon ions if you want to use to target this more resistant area. Remember, the process is straightforward. You build a tracer, which is either a sugar or some other compound that is going to go targeting the cancer. The sugar is the most common one because of the glycolysis, but you have a variety of other type of traces. Okay, now let's get into the dual energy, which is very specific to particles. The dual energy usually means that I don't have one energy, but two energies in my CT scanner. And here are the three types of machine designs from the three manufacturers. You have the Siemens, the GE, and the Philips. And the way you can design a dual energy scanner is you can have a high energy and a low energy together, or at 90 degrees or together, or you can have two layers of the detector to produce this acquisition. So now you have two spectrums, and the spectrums can look something like this. So you have, for example, two spectrums here, the blue and the red, from different machines from the same company. And what you want to do when you do a dual energy scanner is you want to separate the two spectrums clearly. So you have one peak here and the second peak here. And so if you get this clear separation between the two spectrums, you literally have two independent variables that you measure. And this is the big advantage of dual energy. We need the two measurements to create the two parameters that are needed for the producing of the stopping power. So here you see the clear separation is usually done with a filter, tin. So most of the dual energy scanners, when they work in the clinic, they have a medium or high Z filter like tin, and for the higher energy, and they have no filter for the low energy. Okay, so how do we produce stopping power from a dual energy measurement? So when we do a dual energy measurement, we get basically two parameters. We get either the electron density and the effective Z, and they can be composed basically from the two measurements. So basically the two measurements give you a photoelectric effect, which is the left component, and a Compton effect. And you use a parameterization, which is the alpha and beta, to have an idea of what the attenuation effect is that you're measuring of your tissue. And that's what you measure. You measure the alpha and the beta. An alternative way, so this allows you to decompose your tissue into two materials, which are usually called Compton-like material, water, which is the beta term, or photoelectric type material, which is the first term, the alpha. So what you do is you decompose your material with two measurements into Compton and photoelectric type, and you build an image. This is your standard dual energy system used in the radiology department to build images of your patient. The way we use it for particle physics, for particle therapy, is a little different because we need to measure stopping power from the dual energy. So the stopping power also has two parameters that need to be obtained experimentally for each patient. The parameter that matters is the so-called relative electron density. That's the most dominant parameter. And you need to know the I value of your material. These two parameters can be obtained through a stopping power curve. So usually in the stopping power curve or any CT curve, you have to calibrate the curve Hounsfield units, which is what you measure relative to density. And this has to be very precisely done so that you can represent all these regions that are here: lung, soft tissue, bone, soft bone, hard bone. All these regions have to be parameterized in your lookup table, so that you can then say my patient behaves. Certain regions behave like lung, other regions behave like soft tissue, others like soft bone, and others like bone. So here is, let me just quickly go back. Here is the stopping power equation, and here are the two parameters that I need to obtain from the dual energy. And usually it's relatively easy to obtain the electron density, which is the first component. With the dual energy, I obtain immediately the electron density. Is relatively easy to do. The problem is obtaining this I value from this effective Z. And there is a few papers, and the first one was published, the first one was published around 2010 by the group in MD Anderson, and they provided a connection between this effective number and the mean excitation value. And with this approximation, you immediately get a very accurate stopping power estimation for every point in the patient. That's why dual energy is going to become the standard imaging device system pre-treatment in patients to allow to stopping power estimation. So there's a variety of applications, of course. Once you have the system working, you can even do 4D dual energy. And this allows you to acquire, during the breathing pattern, different dual energy distribution, which are, of course, susceptible to the changes in density. So when you're breathing, the lung density changes, and you need to know what that means in the stopping power effect. I will jump this. Okay, so now we come to another problem, which is motion. So treating patients and treating a moving target is extremely hard to do. And the key point here is the anatomy is moving. Okay, we don't know anything about the beam because we are looking at the anatomy. Here is, for example, different images for the same anatomy. Okay, and you see how it's moving. Usually it's in the sup-inf direction, so vertically like that on my right. And this is my treatment plan that I want to deliver. And if I'm delivering to a moving target, it's really a bit of a mess. Okay, so not many facilities treat moving targets. So the proton facilities definitely have really big difficulty in treating moving targets. So moving tumors are usually avoided. The experience that each center has in treating moving targets is very specific to passive scattered beams. So pencil beam scanning is usually not used. And the results are very specific to the center and the patient. So facility characteristics usually vary. You can have passive scattering and pencil beam that are designed. You have a very small spot size or a very big spot size. And you can have scanning speeds, which are very specific to each type of machine. And you also have the patient characteristics can change significantly. The tumor position, the motion amplitude, the tumor site, the respiratory frequency, all these affect the quality of your treatment for moving target. So let's see the periodic train. You have the respiration that has a periodic motion of 12 cycles to 15 cycles per minute. You have a heartbeat, which is much faster. You have 60 beats per minute. And you can even have so-called a drift motion, a relaxation. When the patient usually enters the room for treatment, he or she is a little nervous. Once they settle on the couch, their motion changes and they start to be more shallow in their breathing. The amplitude changes, the whole position changes. So you have to be aware of that. So here's an example of the organs that are affected. You have lung, you have esophagus, which is really hard to treat. You have the liver. And of course, you have also the pancreas, which is one of the hardest ones to focus on. So it's really hard to shoot at a moving target, and it's very hard to fix them. So there is a lot of fixation devices that use motion reduction by applying pressure on the stomach or on the chest so that you have a slower, so you have a small amplitude of motion, but some of them don't work perfectly well. Okay, so the lung and the liver have usually the highest, but they can vary. Most of it on average is less than 5 millimeters. You do have around 20% of the patients which have higher than 5 millimeter motion, but most of them are relatively hard to predict, and they have 5 millimeters. The problem comes when you use pancreas and esophagus. Most of the patients have very large amplitude of motion, and this makes it really hard to treat any type of pencil beam scanning. Like I've said before, the motion direction is usually sup-inf from the head to the toes. And so you always have to be aware of that, and you have to understand how to deal with that. So here's an example. You have a moving target, and you have a pencil beam, and you see that the two have to match, and they are not. So you have a completely blurred dose distribution that should have been uniform. Because of the moving pencil relative to the anatomy, you don't have a uniform distribution. You have this hot and cold region inside the cancer, which is really a problem, of course. So this is usually called the interplay between the beam and the anatomy. So there are two main things that have to be accounted for. The anatomy is moving and the beam is moving. And when you have the interplay between them, you even have a situation where you can really deposit high dose in the wrong place. Okay, so now during treatment, imaging is critical to allow you to mitigate a lot of these effects. And so here's an example of a planned dose that you did pre-treatment, and here's the case of a treatment, a daily treatment. And you see the red region does not look like anything you've planned, sorry. So you see a distribution that is completely smeared with hot and cold regions in it. So what you need to do? Well, this has to be done daily. You have to be able to understand the motion, and you have to understand the delivery characteristics. And so in this case, if the differences are significant, you have to be able to adapt. And so daily adaptation is something that is not straightforward, but with the appropriate imaging devices, you can do that. You need to know what it is. So motion mitigation is about that, aims to minimize these effects on a daily basis by having an idea of what is the anatomy motion, and then potentially adapting if you need to. What are the motion monitoring systems available now in particle beams? The clinical reality, well, one of them is called the Anzai belt. And the Anzai belt basically sits around your waist, and you monitor your motion with an external marker. So the Anzai belt is an external marker. Another one is a breathing mask. And this is a form of mechanical ventilator. And you can even have a surface imaging. Vision RT is a form of surface imaging. And so you image the surface of you, and you watch how the surface moves over time. And finally, one of the most sophisticated systems is the Hokkaido Proton Center, where they have 2 X-ray beams at 90 degrees. You can just about see these orange diagonals here. These allow you to directly measure the motion of the anatomy internally. So you'll constantly have X-ray beams on. The disadvantage is you're giving the patient a lot of X-ray for this to happen. So what about in-room positioning for daily setup? Well, you can do either CT, cone beam, or potentially one day MRI. And so here's an example of a CT that is in room, where you do the positioning directly on the CT. So the couch is rotated towards the CT machine. You do the positioning of the patient, and you rotate back to the treatment. So here's an example. The patient is on an orange couch. It's rotated into the CT for positioning, and then it's rotated back to the treatment room. So that's one way of doing. You could do either CT or cone beam imaging to allow the anatomy positioning. Primarily, CT and cone beam is driven by anatomy, bone anatomy imaging. So one way of doing cone beam is to integrate it directly in the machine. And so this was achieved in an X-ray machine more than 30 years ago, 20-something years ago, in 1999, by David Jaffery and colleagues. And here is the first cone beam system with an X-ray linac. The first proton machine to have it took a lot longer, took almost 16 years, 17 years for it to, and the first center to have it functional was in Texas. Okay, so the future is bright. We are looking at potentially one day having MRI in the room for particle beams. So here's a nice review paper by the group in Sydney, and you can see the possibility of a proton gantry coming in, a proton beam coming in through this fixed beam line, and you have an MRI, and the beam is coming in through the gap to produce a therapy. Could this be the future? I don't know, but it is very present at the moment. There is so many MR linacs out there that do this, and so it is a possibility that protons will also have an in-room MR. And why do you also need to image the beam, right? Until now, I've been talking about anatomy tracking. So I track the anatomy, but I don't know anything about the beam. Why do I need to image the beam? Well, any range uncertainty in the particle beam means that I'm giving the whole dose to the wrong region. Here is, for example, a Bragg peak and a photon beam. And you see here variations in density have very little effect, but a small variation in the proton beam has a shift of the dose distribution. This means I can drop the whole dose in the tumor by 30–40% with a small 1 or 2 millimeter shift. So range uncertainties are got to do with that. We want to know exactly where the beam stops so that we can predict exactly what the dose is given. Here is a simple example of a proton beam that's coming in to treat a tumor that's sitting right next to a brainstem. And the brainstem is extremely sensitive to radiation. So if I have a range uncertainty of a few millimeters, I might be shooting straight into the brainstem with full dose. So I am producing a side effect. I'm producing radiation toxicity with the wrong range. So there are a variety of in-beam tracking systems, in-room tracking systems for the beam. They are primarily developed by IBA, the slit camera. There was one development in Boston that I did with my former PhD student, which allows also for beam tracking directly. And in this case, in both cases, you see the beam. You don't see the anatomy. You have to, of course, register everything towards the anatomy, but it allows us to do the beam tracking directly. There are a variety of other prompt gamma imaging technologies that Nicholas and Hans-Peter will talk about later. Okay, the final part is the imaging post-treatment. So this one is really critical because you really want to follow the patient and you have to understand, was there a recurrence? Was there a failure? And if so, was there also any side effects? So there are two types of follow-ups, the watching for the recurrence and the watching for side effects. So usually the clinician cares mostly about the recurrence. And so the first imaging post-therapy usually happens between 8 to 10 weeks after the end of treatment. And they want to check if anything is going on with the recurrence or with the side effects. Then a second image can happen up to 12 months after treatment. So there is a huge gap between 8 to 12 weeks and 1 year. So this imaging follow-up can vary depending on the location, but they tend to be either PET-CT or CT, and in some cases even an MRI. These are the standard practice now. Maybe in the future with the development of the PET MRI, we will be able to do follow-ups directly with PET MRI. Okay. So imaging plays a major role in all of particle therapy, not only in radiation. There are 3 main stages: the pre-treatment, the during, and the post. We should always look at them like this, because that allows us to understand which one and what their impact is in the therapy. The pre-treatment stage is the most important, since it involves all the needed preparation for the treatment, from the dose calculation to the tumor staging and the organ contouring. The during treatment is very important to allow daily imaging and potentially adaptation. So this one allows you to check every day your treatment is the one you planned for, and to adapt if it's not. And finally, the post-treatment is critical to allow you to assess treatment response and to evaluate the impact of your treatment on healthy tissue. All right, so I think that's it. If there are any questions, I will just go back to the conclusions.
Thank you very much, Joao. Should we take the questions now or at the end of the whole session? What do you prefer?
I can take some of the questions now, and
okay.
I can be back also. I can also be in for the next one, just in case.
Okay, great. Maybe then you can stop sharing your presentation so that we can post the questions. Yeah.
Excellent. Is it true that CT is used?
Go ahead. Thank you.
Is it true that CT is used more for imaging because CT is cheap and easier to combine with PET? No, I think it's just a matter of technology that has matured. The CT technology is the one that matured fastest, and recently with integration. So the first CT PET integration occurred in the early 90s in Pittsburgh with David Townsend and company. But it was the one technology that matured very quickly. So it's the one that entered the application very quickly. It's a matter of maturity. The dual energy CT is only really matured in the last 5 to 10 years, and so it's now entering all the proton clinics now. All new proton clinics have dual energy scanners. So the CT is really hard to monitor patient movement, but it's possible. You can do 4D CT images, and you can build 4D CT images to have an understanding of the impact. Ideally, you want real-time monitoring, and so either a fluoroscopy system or external tracker, like the Anzai belt or something like that, is the best way to monitor. To minimize movement, it's difficult. The only way to minimize movement is to the patient stop breathing. So technically, that's very hard to do, of course, but there are techniques out there that allow that. So there's something like the ABC, active breathing control, that gives the patient a 30-second breathing stop, but it's not so easy. Is there a way of monitoring movement during irradiation? Yes, the MR Linac is exactly that. The MR machine directly in beam allows you to do that. Or the system in Hokkaido, which is a fluoroscopy unit that can run at the same time as you're treating the patient. So you can either do X-ray fluoroscopy or MR live with the treatment. If we can match the movement of the radiation with the moving part, means the radiation is having the same movement, then can this problem be solved? So ideally, the future is to match the beam movement with the anatomy movement. Remember that there are 2 completely different things, and you want to match your beam to your anatomy so that you can really get the correct treatment. This is not so easy because you need an anatomy imaging device to match perfectly with a beam imaging device. So I think Hans-Peter will mention these things more carefully, but you have to match the 2 in order to get the perfect correlation. What kind of dual energy would you recommend for particle therapy treatment planning, for example? So there has been a few papers on studying the different manufacturers, comparing them. I am preferably in favor of one of them. It would be really disadvantage for me to say it publicly since I support one of them. But I suggest that you read these scientific papers. You can find them. That they have compared the GE versus Siemens versus Philips versus all that, and there's some advantages and disadvantages of each one. And if you're looking to buy one, you can write to me and I can make some suggestions. Is it possible to synchronize movements with irradiation? So the movement is never the same. So in every cycle of movement, the anatomy has moved a little bit, either in one direction or in another. What we try to do is gating. So although we know the moving is different, the phase that is most reproducible is the expiration phase. The expiration phase is the most reproducible. So we try to gate our radiotherapy treatment to the expiration. So when the person is breathing out, we gate the treatment for that. So it's easier to do that than beam tracking. It's a lot harder with beam tracking. So gating is the technique to sometimes to minimize motion in the case of treatment. So the resolution of the different images depend what you're looking for. An MRI can reach atomic level if you have a small magnet bore and stuff like that. From a patient perspective, they're all more or less equivalent. They can reach around 1 millimeter cubed, so it's more than enough for what we need. Most of the CT can do 0.5 millimeter, and the same thing for MRI. The PET now has a resolution of around 4 millimeters, and maybe with the time of flight, that might be going lower. Okay, so where is the question? How can you increase resolution of MR scans? So the MR scans, there are different ways to increase resolution. One of them is to decrease the bore size, which is not so easy because of patient size. The alternative is to increase the magnet size strength. So as we increase the magnet strength from 7 to 14 Tesla, or even one day to 20 Tesla, the resolution can get better. Although you don't really need so much improved resolution on the MR or CT. What you need is function. The most important drive for imaging now is functional imaging. We want to know whether the tumor is active so we can target that. How typical is adaptive RT in particle therapy? It's not typical at the moment. Most centers do not do adaptive RT. They are all moving towards adaptive RT, but most of them don't. Usually they might do a weekly adaptation, but not a daily adaptation. It's not so common. There are a variety of reasons to do with sometimes legal situations, sometimes QA of the new plan, but it's not done daily in most centers. So the adaptation might happen once every week or 2 weeks when the doctor requests a second CT. So what is the percentage of error of beam delivery due to motion? It's pretty big, but it really depends on the organ motion amplitude. So how much does the organ move? So it's difficult to really make a number to it, but the amplitude does affect the quality of your treatment. So that's why we try not to treat moving targets that have high amplitude. So in the HIT, there's a variety of motion amplitudes, Anzai belt. Now they're trying to do MR before treatment to get an idea of the motion. And there is no real-time imaging during treatment. There was installed a cone beam system that was supposed to be used, but it was never really fully commissioned. Can we use spectroscopy for motion monitoring during the radiation? Yes, you can use prompt gamma spectroscopy for motion monitoring during radiation. And that's how it works, but you're monitoring the beam. You're not monitoring the anatomy. So you can see the effect of the beam on the geometry, but it's not so straightforward to see the full anatomy of movement. So do I believe that real-time MR guidance will be implemented soon in the clinic? I am not sure if it's going to be implemented soon or not. I know the MR LINAC has taken a big jump and shown the importance of having real-time imaging for pancreas, especially for pancreas. But it is extremely expensive to build an MR inside a proton center, a proton room. So it's going to take some time until they develop a feasible solution. So it's not so easy. Is it possible to integrate PET and MR in the same equipment? Yes, it's been done. The first commercial system was available since 2013. And you just have to replace a lot of the electronics, like the PMTs have to be replaced by solid detectors. So you cannot have a photomultiplier tube because the magnet will affect its response. So you usually have solid detectors. Okay, so maybe those are the questions.
Joao, since there is now some time left, I suggest to ask participants live if they have some questions. But before doing that, let me use my advantage as a chair.
Sure.
I have a question.
Absolutely.
Actually, in one of the Enlight meetings in Cannes, when I was present, I was kind of impressed by a presentation that I really don't remember who gave this presentation, of a method that it was possible to provide enough oxygen to the patient so that practically breathing stops. Which sounds kind of frightening, and I have no idea how this can be done, but you have any comments on that?
No, I heard about it too. It's a method that is developed somewhere in the UK where they give a very high level of oxygen in each inspiration that the person requires less times to breathe.
Mm-hmm.
So I think it's a really nice idea. You can reduce the amplitude and the frequency, and I think it's a really good idea. I don't know if it's something that can be done for patients that are usually very weak. So it's usually good for patients that are healthy. So most of the population that are treated in cancer are usually weak patients. So if you're asking them to take a whole breath of oxygen, that's difficult because they might just stop breathing permanently. So it's not so straightforward. But I think it's a good idea for healthy patients that you want to treat. So I've heard of it, and it seems like a really nice idea. Yeah.
Okay. And there is actually a comment in the chat.
Yeah,
So
I remember hearing about it, and I was also, wow, this is really nice.
Mm-hmm.
Yeah, exactly.
Okay,
It's in the UK. I know it's in the UK, in Birmingham. Yep, thank you.
Yeah, thank you. So I suggest that participants either unmute themselves, or if they want to type in the chat to use the time if they have more questions. And possibly not only for today's presentation, but the previous presentation of Joao, to take advantage of the time.
Yeah, I tried to connect the two presentations, so there was a lot of the stuff that was connected. So you're welcome to ask questions about them. Most of you might not have experience in biology, so I tried to bring it down as much as possible. But the biology is really important. We physicists tend to forget the biology, and it's critical for what we do.
Don't be shy. Actually, through some emails, will you talk about the prompt gamma imaging?
So Hans-Peter will talk about prompt gamma and different prompt gamma systems. I will be present to help with some of the questions. But yes, Hans-Peter will mention the various prompt gamma systems.
Hi, could I ask a question?
Yeah.
So I was involved with some research that did some helium carbon ion mixing to do some sort of online range measurements after the patient. And so a big consideration with that was how that sort of range information is used in a clinical setting. So if there is a discrepancy between what you planned and what the resulting range measurement is, at what point do you say, okay, we need to stop, we need to replan this treatment, we need to change something? So is that something that in a clinical setting is being thought about with this sort of online treatment, online sort of range uncertainty or stuff like that?
So stopping a treatment is usually something you don't want to do unless it's really a major problem. So in a situation like that, when you do online range monitoring, the first stage would be to adapt the treatment the next day. It's usually the best way of doing adaptation, but there are different ways. So if the treatment is really, really wrong, of course, you have to stop it immediately. But since you have many, many fractions to treat, you can do daily adaptation by incorporating or correcting today's error in tomorrow. Okay? So adaptation is something that is usually based on that principle. Because we have a lot of fractions, we adapt the next treatment. Stopping a treatment is a big problem, and if you stop halfway, then even worse. So it's better to try to give as much of the dose to the patient on that day, and then understand what small amount of dose went wrong, and then to correct it. So the daily adaptation would be along those lines. Most of the daily adaptations along those lines. But it's not a straightforward problem to stop a treatment in the middle.
Interesting. So any other questions? Please don't be shy. Either ask online or type.
Corey raised hand, so please talk.
Hello. I noticed that for the stopping power ratio calculations, you're using the Bethe block formula.
Yes.
My understanding is that that's valid for like very high energies sort of thing, but at lower energies, it starts to become invalid. How does that work? Because like, especially around the Bragg peak region, the particles are slowing down.
So yes, but we usually have a pretty good idea of where the Bragg peak is because we measure it. The problem is all the way up to the Bragg peak, and those energies are usually in the 90 to 220 MeV, and we need to know those. And the Bethe block equation is really an experimental equation, so it's not a perfect fit. So if you look carefully at the equation I gave, I'm missing all the correction parameters because we're fitting the parameters experimentally. So it's a so-called experimental Bethe block. Relative to the Bragg peak, you're right. The Bethe block needs to be corrected for these low energy corrections. But at the end of the Bragg peak, the shifts are usually small. What we need to do is to know exactly where it is, so up to the Bragg peak. And there the energies are high, right? So if you shoot a 90 MeV or if you shoot 100 or 120, you need to know how it attenuates through the tissue until it gets to the final, let's say, 3 or 4 centimeters. That's really why we use that Bethe block. At the end of the range, it's not so much a problem anymore. It's the build up until the end.
Okay, thanks.
Okay, thanks for asking the question and as well for answering. Let's see if we have any more participants with raised hands.
I see 2 questions, maybe I misunderstood. Can you explain the need for mitigated for uncertainty with respect to the biological parameters? So in the case of the protons, the RBE changes significantly at the end of range, especially related to the LET part of the protons. So any small variation in the positioning in the distal fall-off can affect the biological effect, okay? And the same thing applies for carbon. So the biological impact of the radiation, the uncertainties can be significant by just shifting this high LET region or this high RBE region. So it is important to know where. MR guidance is really promising technique in radiotherapy. Is the implementation of this technique affected by financial aspects? Yes, of course. Everything is affected by financial aspects because someone has to build it and someone has to buy it. So yes, so the problem is one part of it is financial, the other part is the maturity of the technology. Yeah, you have to get the technology to be mature for it to work. Is the AI techniques currently used in clinic for image-guided radiotherapy? So no, AI techniques are creeping into the clinic. They are starting to be used in a variety of sections like auto-planning, MR to CT, and a variety of systems, but they haven't all gone fully clinical. So they are still, let's say, in the translational phase from research to clinic.
Okay, great to see participants being more interactive and hear some real voices from them. Some more comments, anybody? Please unmute yourself, raise your hand. Any further questions?
Well, like this, I give some extra time to Hans-Peter. I think he's next, right?
Right.
Yeah. Well,
No, I am
Nicholas.
next.
Oh,
I am
Nicholas. Sorry, Nicholas. Sorry,
Nicholas.
I didn't know. So Nicholas is next, and then Hans-Peter will be after. All right.
Yeah,
exactly.
Yeah. Maybe one.
Yeah, go for it.
Maybe one comment regarding like the MRI implementation in therapy. I don't know because I wasn't there the last 5 minutes actually. If some comment came up, but actually there's like quite a big project at the moment going on at HIT in together with the University Clinic and Heidelberg and DKFZ, right? This Artemis project, which actually aims at this to build prototypes and evaluate what you have to do to integrate it. So that's actually like considered, but of course it's not an easy problem. That was just a comment on this question.
Yeah, great. Because it's a little bit of a pity that there are negative aspects that come from the positive aspect that heavy ions are so accurate, and this is a strong point, and then this tends to be a disadvantage, but it's due to other reasons, no? So hopefully the other reasons will be worked out and resolved. Okay, so Niklas, then I suggest that you start.
Yep.
I can already start. So yeah, this breaks everything a little bit up because probably it would be also nice because Joao also thought that Hans-Peter would talk, not to directly talk about the prompt gamma and stuff like this, but we mixed it a little bit up. So it's also a preparation for this afternoon's practical. Because Joao started to mention a lot of the uncertainties, and you saw the kind of say applied way to deal with it in the treatment room and in the imaging rooms, taking more images, taking better images, and so on. Try to adapt, but there's also a side on planning that deals with how to quantify these uncertainties and how to mitigate them in planning, and that's basically what I'm going to focus on. The talk is not very long, so let's see if this overview or like this mix of overview and some details, because I'm also a little bit biased in the methods, of course, given the own stuff that I do, if this works. But let me start sharing my screen maybe. So here we have it. So I changed the title a little bit compared